Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Leveraging AI and Machine Learning to Improve Your Enterprise, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Geneia. Just a little housekeeping before we get started today. I'll be your webinar moderator. My name is Anthony Guerra, and I'm the editor-in-chief of HealthSystemCIO.com. We're hosting a tweet chat, an integrated simultaneous tweet chat that's going to be hosted by Kate Gamble, our managing editor and director of social media. So you can go ahead and open a Twitter window and continue the conversation at hashtag HSCIO chat. You can ask questions today by typing them into your Q&A box in the lower right-hand corner of your screen, leaving the default set to all panelists. We'll be posing those later in the program, but you can send them in as they occur to you. You can download the deck using the URL on your screen, and we've got a shortened URL at the bottom of all slides. And we are recording today's event, and we'll have an archive ready within 2 business days, if not sooner, and you'll get an email as soon as it's been posted to our YouTube channel. Just so you see how we're going to spend our time today, we're going to go about 30 to 35 minutes on our panel discussion with Chuck Podesta, CIO from UC Irvine Health, Dr. Shafiq Raab, VP and CIO at Hackensack University Medical Center, Heather Lavoie, Chief Strategy Officer with Geneia. So before, without any more delay, we're going to begin our conversation. So let's start with you, Chuck. Tell us a little bit about UC Irvine Health.
Okay, great. Thanks, Anthony. Thanks, everybody, for taking time out of your busy schedules to join us. Hopefully we can give you a lot of good information to take away. But I'm the CIO of UC Irvine Health. We're an academic medical center in Orange County, Southern California, and we're one of the 5 medical centers in the University of California system. And we have a pretty large Hadoop ecosystem that we built working with a startup company, and we'll be incorporating many of the technologies that we'll be talking about today. So hopefully able to impart some of those things that we're doing with those technologies to all of you.
Very good. Dr. Raab, you want to tell us a little bit about Hackensack University Medical Center?
Good afternoon. Thank you for having us on this call. Hackensack University Health Network is presently a 5-hospital system academic medical center in northern New Jersey. We are going to open up a new medical school. We are deeply involved in research and academia, but at the same time, we're also into population health, and we also are going to merge with the largest system very soon and become 14 hospitals. That means we'll have a big impact on healthcare in the state of New Jersey. And today we'll be discussing artificial intelligence and machine learning, which are the futuristic things that people are talking about, and we are including that into our data, and I congratulate Anthony for putting this topic on the agenda, and Geneia trying to support this, so I'm grateful for that. Thank you.
Thank you, Dr. Raab. Heather, you want to tell us a bit about Geneia?
Sure. So thanks, Anthony. Thank you, Chuck, and also Dr. Raab, and for those of you participating today, we appreciate the opportunity. Geneia is a healthcare technology, analytics, and clinical services organization, and our mission and our focus is really to transform the way healthcare is delivered and improve the lives of the people that we serve. We're a mission-driven organization, and our focus is really at that intersection between population health and personalized care, and we build solutions that really align each person involved in both administrative as well as clinical care delivery. And right from the start of our organization, we believe that for population health to really work, the tools, the process, the incentives needed to be aligned across health insurance payers, including CMS, employers, providers, patients, and the entire care team. and that we also have been really focused on preserving the primary care workforce and also levels of physician satisfaction, and we've been pushing to move away from just a digitization of the clinical record in EHRs and moving to a more fully enabled model that really raises up individuals to work at the top of their license. And we serve about just over 1 million patients currently across our products and services.
Very good, thank you. Again, that phrase I've been hearing a lot recently, individuals working at the top of their license, so we can touch more on that later in the program. Chuck, let's start off with you. Talk about what you're doing with AI and machine learning and sort of your vision for what you might be doing down the road.
Sure, Anthony. Well, first off, just a few points about AI and just the way we view it here at UC Irvine and working with clinicians. It's one thing that's not well understood in healthcare at this point. So there's a lot of education that we need to do, especially with the clinicians when you talk about artificial intelligence, because the first thing and machine learning, the first thing they think about is that, the machine is telling me what to do. It's kind of like the fear around electronic health records when the physicians, clinicians start thinking about cookbook medicine. You remember those days. And this is similar to that in that, it's a term not well received by clinicians. So we've actually flipped it and called it IA, intelligent assistance. So it's more of an assistant decision-making and, based on experience-based or evidence-based medicine, but not telling them, giving the impression or the perception of telling them what to do. And success of this is really based on, clinical acceptance of AI and ML. So you got to be careful about the perception and the terms that you use, and things like, prescriptive analytics. We use suggestive analytics here at UC Irvine. So we're really trying to look at it from that standpoint. So, for example, we're using some AI and ML technologies to look at, a particular patient in the last 30 minutes, the physician's patient, the clinician's patient, has a drop in blood pressure by X amount, an increased heart rate and respirations by X amount, and then the following labs have come in, and the results of those labs are X, and then putting that all together to say, this patient you might want to look at, and these are the areas that you might want to focus on. But again, it's around suggestive. It's not the machine taking over the care of the patient, anything along those lines. So I just want to kind of start out with that. I think it's very important to put it in terms that the clinician understands before you embark on this.
So the terminology matters, and the way you present it matters. Dr. Rob?
Well, I totally agree with what Chuck said, but at our place, what we are doing is that, first of all, pattern recognition and the way same thing happens over and over again, and also the way people practice medicine, trying to understand that. And what we have done is that we have partnered with the physicians and the practitioners so that they can see their data and they can see how we are introducing artificial intelligence, or ML, machine learning as we call it, in the data set. So what that really means is the following, that if certain things happen, can we say that the next things will happen or not? So to predict that, that thing, that machine can learn that and can automatically suggest that. We are not at a point where we can say that it will take over the diagnosis away from the physicians, or it will take the care away. What we are saying is that we are using the data to better understand the patient itself. We live in the era of precision medicine. We live in the era of personal health care, and we live in the era of population health. To make that understand, the part of the data sets that we have, they are now being incorporated into logarithm that allows us to understand what will happen in the future. So that is how we are looking at it. We are looking at it more as a research tool, and we are looking at it more as a business intelligence tool.
Okay. Heather, you want to touch on that a little bit?
Sure. Well, as an analytics company, we apply machine learning to find patterns in the data, and we use that to more effectively predict rising risk in patients. We look to see causality in health decomposition, and also try to identify or pinpoint when health decomposition begins to occur, so that we might be able to provide then an appropriate intervention and an early intervention. And so I agree with both Chuck and Dr. Rob. You know, we're not using it to replace physicians in any sense, but actually do a lot of the work that is, you know, I think too much for physicians to necessarily take on a day-to-day basis in looking across the population and identifying the patterns. We also use it to identify based on an individual's preferences, based on some of their, you know, personal history, consumer history. We determine some of the most effective solutions or the appropriate next best action to take with an individual, which also helps in terms of being more efficient in some of the interventions. So are they likely to participate in a program or not, and what program is the most effective for them, and to do that at an early stage. So we're really doing it to help better educate the system as opposed to necessarily replacing care to get all together.
Yes, that wouldn't. That probably wouldn't get physicians too excited, right? If we positioned it as training their replacements, so we want to stay away from that. Heather, let's stay with you. Can you give us an explanation or a definition of AI machine learning? Are they interchangeable terms, or do you think of them differently?
So, you know, this is a question that can evoke a lot of philosophical debate as to whether traditional AI is actually even what we consider artificial intelligence at all. And, you know, really machine learning is a subset of a broad category of AI, so not necessarily interchangeable per se, but certainly a subset, and many may argue a far more effective, you know, component of rather than the broad category. And if you think, you know, kind of going all the way back to the beginning, back in 1843, we had the first computerized algorithm that was written by Ada Lovelace, and it was a base 10 system, same foundation that we rely on today, and the programming, you know, based on logic, ultimately included advanced statistical modeling that became more and more expert over time, and so expert systems under that big category of artificial intelligence. But it still relied on lots and lots of humans to do the programming, to do the coding, and so string lots and lots of code together to be expert. And so machine learning is really considered the scientific discipline that deals with the construction and study of these algorithms, but ones that can learn from the data directly as opposed to being explicitly programmed. And they operate based on a model that uses inputs to make predictions or decisions. So in the same way that we've discussed, really trying to predict when health may decompose and help to aid in decision making. And classic AI relies on, you know, some degree of human feedback intervention and can work with smaller data sets. Neural networks are what we think of often when we're thinking about machine learning today, learn from patterns in the data and classification methods, and it's less complex in terms of lines of code, but it requires very large data sets to be effective. So hopefully that's sort of a, you know, kind of good definition of splitting the hairs between AI and machine learning. I don't know if Chuck or Dr. Rob have anything to add there.
Well, I mean, I cannot say more than what you have said, but I can give a simple example and you can categorize what it is. If it's an OR schedule for an operation room schedule, and if you feed the machine the data of the last 5 years, who the surgeons were, when they take the vacation, what the weather was, how many cases were done. So now you have weather, you have traffic, you have the surgeon's preference, and you have the data about the type of patients who comes to your hospital or your healthcare system. Based on that and the staffing, that the staff you have, when they get sick and how many times they have taken their vacation during certain time, and then you put their age, and then you put how many children they have, and who's going to get married when, and what the education is. The machine learns all that. Based on that, the machine can predict to you that every Tuesday your OR will have more patients than every Thursday, because that's what the machine learned. While artificial intelligence goes above that, machine learning is a subset of artificial intelligence, but artificial intelligence is one degree less than human intelligence, is that it can extrapolate from there and give recommendations to you. That's the way I think that artificial intelligence versus machine learning.
Chuck, we got to hear from you now.
Sure, that's a tough act to follow, my friend Shafiq. That was a great analogy. I was just going to add that, you know, I look at it, if you look at it from a robotic standpoint with a robot, you know, the robot takes the machine learning, the patterns of data that have been created, and then does something with them. So it turns left, it turns right. It, you know, it does those things, you know, based on the understanding of patterns of data. So, but I'll leave it at that because I love Shafiq's answer.
All right, very good. Oh, go ahead.
100%. You know, for example, Anthony, if I'm an asthmatic, would I not like to get up in the morning and be told, don't take I-287, take I-80, because take I-287, not I-80, because there's so much traffic there today. So somebody collects that information and comes to me as an asthmatic not to take a drive somewhere where there is a lot of fumes there. So there's not only for physicians and other people, machine learning and artificial intelligence. These things are very cool to add other data into daily life. Now, I'm going to keep quiet now.
Okay, very good. All right, let's go on to the next question. Let's start with you, Chuck. How do individual patients benefit from machine learning? What is your vision of that?
Well, just you know, if I talk about it from a, excuse me, from an inpatient perspective, we actually have an ongoing project right now that might illustrate a little bit of that. Is that we collect all of our monitoring information from the units in a 1-minute interval that comes into our Hadoop ecosystem, and we've been doing that for years now. I think about 4 years. So we have a lot of data, you know, in a 1-minute incremental capture. So what we're looking at is we're focusing on patients right now that have crashed over the last 4 years, and then looking at patterns in, depending on what was going on with them, you know, 30 minutes before they crashed, 60 minutes before they crashed, you know, even, you know, hours before they crashed, and using machine learning to start looking at the patterns of the data to see if there is any commonalities around some of these patients based on the, you know, the issues that they were having, that then we can use from an artificial intelligence perspective to give suggestions back to the physicians in real time. So you know, we have a patient today in the ICU, and that patient is displaying some of the signs of a patient or a group of patients that you know, crashed, and so 30 minutes or 60 minutes before we start seeing some of those signs based on algorithms that were created by machine learning, then we can notify that physician, you know, there's a 80, 90, 95% chance that this patient's going to crash in the next hour or 30 minutes. And these are some things you might want to look at or you might want to do to prevent that from happening. So that's an actually ongoing case study that we have going right now to see whether that's even possible to do. So it's pretty interesting. So I'll leave it there. I mean, there's many, many other examples, but I want to make sure my colleagues have a chance to respond.
Dr. Rob, what are your thoughts on that?
Could you repeat the question again, Anthony, so I can follow Chuck's
how do you see? Sure. How do you see individual patients benefiting from machine learning?
So, so we are doing little. We have some experience with artificial intelligence. So what are we trying to achieve in healthcare by using artificial intelligence? That is the question, and how it helps individual patients. So what are we trying to do in healthcare? We're trying to do two things, and Heather alluded to that. See, we're trying to do two things. One, we are trying to change behavior or adjust behavior so that health of the person can become better. Second is that we are trying to prevent people who are not at high risk now, like people who are pre-diabetic and are not diabetic now, to go into that phase. So what it does is that, for example, if you learn artificial intelligence on a data set, how many times a patient has missed the appointment, what are the types of people who actually miss appointments? What is the reason behind it, whether it's a social determinants, is it because of some other reason? So those kind of things are easily understood by artificial intelligence and learning of behavior patterns that allows a care coordinator to intervene. That gives you, I have used the word of the third window. You know, the first window was when Galileo looked up into the sky and found the stars. The second was when Louis Pasteur looked into the telescope and looked at the germs and came with pasteurization. The third window that we have in our lifetime is the insight into humanity, and that comes into understanding the big data and the artificial intelligence and the machine learning. So for each individual patient, if you can guide that patient, as I call it, that human person, that to understand the person better and to predict the person better and to understand the different data sets for the whole population, now who are the people and why do they miss an appointment? It may seem very simple, but the thing behind the data allows us to understand that. So that's the first thing that helps us from letting not people go into the next phase of it. The other thing is that at one time, a doctor or a physician can think about 5 things or 6, or maybe some physicians are very smart, they can think of 9 things. But if you have machine learning and artificial intelligence supplementing that, that allows the physicians to think of things that they have not thought through, or think of correlations that they have not thought through, and it comes up in front of them on the screen at the point when you're looking at an individual patient. It helps them in the treatment of the patient. Those are the 2 things I can think of the head.
Very good, Heather.
Great. I actually have an example, I think, that speaks to both what Chuck and Dr. Rab said, and it's not from Geneia, but actually from a fantastic data scientist whose name is Mike Dragoulis. And he was at Lockheed Martin, but now he's at Penn Medicine, and it actually relates to sepsis. And which is a thorny issue, and every second matters as a patient sort of plummets towards death in sepsis, and yet diagnosing is, a pretty big challenge. And the best clinical judgments, sort of evidence-based guidelines in this regard, rely on clinical interpretation and review of health indicators. And that best clinical judgment has about a 69% detection rate with about a 35% accuracy rate. So a lot of false positives, which for physicians is a real challenge. You're taking, you're making interventions that you maybe shouldn't, and or you're not necessarily, and you're getting a lot of misses. And so Mike took the machine learning system that's actually currently used for our missile defense system, our concrete shield, and applied it to the problem of sepsis, evaluating clinical measures such as heart rate, respiration rate, blood pressure, temperature, lactate, which Chuck was alluding to in terms of all the data points that we're getting out, from inpatient stays. And the system was able to, and it was even just in, short amount of time in terms of training the system on the data, it was able to pinpoint which measures correlated to sepsis and which did not. And it was able to predict a 90% detection rate with 99% accuracy and 24 hours earlier than best clinical judgment. So when every second counts, a 24-hour leap forward is huge, and 99% versus 35% accuracy rate is also tremendous. And so, you know, that's sort of one small example of how machine learning can revolutionize healthcare and can better empower physicians to get done what they need to get done, because it is difficult for them to process all of these different pieces of information across every patient in every moment at any given time. And so it really can be an enabler.
Very good. Now, let me set the table for sort of the next point of our discussion. The way I see it, there's the data that's being fed into the system that's doing the analytics, and you have the quality of that data, you know, the whole garbage in, garbage out thing. So you need good data coming in. You need, you know, there's all algorithms and all analytics are not equal. So then there's the quality of the analysis that's being done. And then outcomes recommendations that are either then accepted or not accepted. So you almost have a three states. Let's talk a little bit about the third state right now, which is the willingness of folks to accept what comes out as a recommendation. I'm going to ask Dr. Rob in a minute to specifically talk about physicians, but Chuck, in a broader sense, talk a little bit about the willingness of folks to accept. And you did make the point about these are suggestions, and that helps them sort of be digested without being rejected quickly or sort of viscerally. But tell me your thoughts around that.
Yeah, I think, you know, when you think about the clinicians that I mentioned earlier and the suggestive approach, I think, you know, as you pilot these things, I think, you know, I'm a big fan of proof of concepts and pilots. So, you know, the previous example I talked about with patients crashing, you know, we're piloting that with a small group of clinicians, and what you want to do is really to give them enough information that shows them that there's value to what's happening here in their practice. And that to me is the biggest key, is that you're not overwhelming them with data. It's not an electronic health record where they've got to document into, you know, all the things that cause them pain and suffering in their clinical rounds. In this particular way, you're actually using machine learning to really get to the concise data points that they need to really take care of the patient. So if you use that in a pilot way, which is what we're doing on the patient crashing scenario, and doing it in a suggestive way, and then what they need to do is, once they respond to that, you know, in the case of the Heather's sepsis example, if they go, they get a 24-hour notice that they need to do something, they go and do it, and they see the outcome of that, then, you know, it will very quickly, the word will spread that this stuff actually works. So again, it's not something you're going to turn on and all of a sudden get, you know, physician adoption on this or clinician adoption on it. But, you know, if you do it in a pilot way and start to build that trust, then, you know, then you have a good shot at making it happen in your organization.
Very good. Dr. Rob, thoughts on physicians embracing, whether they'll embrace it now or what it's going to take for them to really embrace suggestions or advice or directives that come out of machine learning and artificial intelligence systems?
So I was on a plane, and the plane was coming from somewhere to go to Newark. A call came, is there a physician on the plane? 3 of my physicians were flying with me. They raised their hand. I reluctantly raised my hand, but by that time they already got there. And they looked at the patient. His heart rate was not coming down. So, you know, usually the pilot is in charge of the plane. And we decided that the person needed immediate care. And by just nodding the head, we got the plane diverted to Chicago, and the patient got an ambulance and was taken care of. The thing in any job or any work or anything, one thing we have to always remember and remind everybody that at the end of the day, the patient or the person came to see the doctor, not the machine, not the artificial intelligence, and not the IT guy. They came to see the doctor. And that's number one, that's the advice that you're asking. Secondly is that whenever we do any project of any kind of anything at our place, luckily and fortunately, it is started by the clinical people and the physicians, and they work with us and we work with them to do anything together. So not to bring the physician at the end of the day after you have finished everything and say, can you check it out? It doesn't work that way. They have to be part of it from the beginning. Third, as Chuck said, that we're trying to resolve what value are we bringing and what problem are we trying to solve. So if it's a matter of bundle payment, if it's a matter of understanding the patient better, so if artificial intelligence and machine learning is part of something in which we are trying to solve a problem, not as a thing by itself or not as like a new project, it doesn't work that way. It's just a small cog in a wheel to use it that way. And lastly, any kind of data, any kind of information, whether it's artificial intelligence, whether it's machine learning, whether it is, they need to be validated multiple times. And as I always say, that every life is important, every encounter is important, and every information that a person gets at the time that they are supposed to make an information about it, they have to make a judgment call. Sometimes machines also fake out. That means the glucose level looks 500 on a glucometer, and we don't believe it because maybe the glucometer is wrong, and we take a second check of the blood glucose to make sure that it is right. So that element never goes away. So the short answer to this, artificial intelligence, machine learning is a good tool, but it still needs to be validated by the person who's taking care of the patient.
Very good. Heather, I want to come to you now. The way I broke it down before with sort of data that goes in to, let's say, the analytics package or however one want to describe it, then there is the analytics package itself and they're all not created equal. These are different ways of looking at the same package of data, and they may, based on how they're set up in the algorithms, spit out different recommendations. So can you talk a little bit about that and maybe explain a little bit about how Geneia goes about analyzing information?
Sure. So we have both constant streaming data that comes off of devices, a patch device in the form of respiration, heart rate, position, movement, as well as then supplemental data, again, that is transmitted wirelessly, but in the form of EKG readings, blood pressure, pulse oxygen level, blood glucose, and more beyond that. So we take the data in and then we apply it to broad data sets, and so we use techniques such as principal component analyses to assimilate the data along with claims, clinical, consumer, actuarial data, demographic, psychographic data, and we look at intervariable interaction. So we see patterns and clusters in the data, and that we use that to make inferences about causality and combination, like whether a high blood pressure reading means the person actually has hypertension or whether it was situational, if they had enough of those data points. We also use binary logistic regression to identify predictors and to develop scoring mechanisms, so risk scores for patients to identify how, how likely they are to have a significant health burden. We also take the data in and we use the classification methods to determine gaps in coding, the next best action to take with the patient. We use propensity models and we use the data to see whether they are likely to engage in a care management program or to enroll in one insurance product or another, or whether they're likely to complete a health assessment or follow recommendations. And then we also use some, the data in addition to some standard analytic methods for attribution and confinement, identification of disease cohorts, and for quality measurement as well. And then we also apply neural networks when the relationship between certain variables is unknown. So we may be applying it and have other data points that come in, and we're not quite sure of the relationship, and so we use neural networks in those cases. So in a whole range of ways, what we're not doing currently, and and part of this speaks to the adoption and acceptance, is we're not taking the data verbatim and sending out an exact recommendation to a physician or a clinical team member to then intervene on behalf of a patient. We use it for trending. We use it for recommendation purposes. We use it in the broader context. To provide a better risk assessment on individuals, as opposed to do explicit treatment based on the end result of it.
Very good. All right. Go ahead, Dr. Rob.
I was going to ask Heather to elaborate on the neural network for our listeners, so that and for me.
Heather, you want to talk a little bit more about that?
Sure, happy to, because you're going to test me to the best of my ability. So, neural networks are learning algorithms that sort of, I guess in the easiest sense is to sort of follow brain computing, but neural networks sort of are used for discovery to fill in informational gaps. And so I think a good example that sometimes is heard is images of, people see images of cats, and then you might see a partial image, and neurologically you can actually fill in the missing pieces because you have seen enough of this that you can then identify a not full image and identify it then as and attribute it to as a cat because you have enough pieces of information and you have enough exposure. And so we have some of that as well in terms of seeing data and being trained on data over time. We can actually fill in the blanks in many cases based on all of the other pieces of information around it.
Dr. Rob, does that work for you?
That's perfect. I just wanted to let you know by 2026 we'll be able to download our brains.
Well, that dovetails perfectly with the next question. So let's start with you, Dr. Rob. Go a little futurist on me. What do you see going on in AI and machine learning in 5 to 10 years?
I think in 5 to 10 years, privacy will be gone, looks like it, because machine learning and artificial intelligence will help us a lot. It will actually become individualized, and each one of us will have our own app and will give us an insight into our own lives, which we can tap into based on our behavior and based on our genomics, proteomics, our location, our spending habits, and our social determinants, and they tie into Internet of Everything. All those together, the data that will be collected about ourselves, the machine will profile us and will allow us and give us the deep insight to us at the time when it is needed so that we can change our behavior. At the same time, it will become more in tune into gamification in a way that we love to do things like the way we like to listen to our music, and healthcare will become more of a second nature to us, and will also allow us to take care of us long before we get into a deep trouble. So I think with the information we'll have in us, the only thing left as human beings, what are we going to do with it? It will not take the place of our mother who tells us to do everything, but we will have the ability to do that, and it will know what triggers us to do what. We will not be experiments of Pavlov, but we will actually have the ability to make that decision and to make our lives better. That's what I think. I also think that the physicians and the healthcare providers will also have a better ability in understanding us and allowing us to lead our life in the 95% of the time that where we are well, not the 5% of the time where we are sick, and will allow us to become better at that time.
Chuck, what do you see?
Sure. Just to add on to Shafiq's comments, you know, I don't believe even in 5 to 10 years we'll truly get to the point where ML or AI is truly diagnostic. Again, I think it gets back to that intelligent assist component of it, of AI or IA. So for an individual, and I'll give you an example, like right now, you know, people wearing the Nike Fitbits and everything, and that's, you know, that tells you that, you know, you woke up 7 times last night. Well, that's great, but it doesn't tell you what you need to do so that you don't wake up 7 times, right? No, at night. So it's really a one-way collection of data. So I think to get to Shafiq's point, you know, in the future, it's not only going to say that you woke up 7 times, it's also going to say it's because of knowing you and you know what you ate and what your habits are. It's because you know had you know a certain type of meal or certain you know something happened during the day that caused that. And so that's it. And again, those are all going to be suggestions. The real difficult part about this is the behavior side of it, and that's why I think on the teams, you know, you're going to have data scientists on your team, but you're going to also have behavior psychiatrists, psychologists on your team, because to get people to look at when a suggestion comes to say, you know, if you go to the gym and do an hour workout, this is what your vitals will look like, and you know, just a variety of different good things that will happen, but you've got to go and do it. So, or don't eat this particular thing right now, or, you know, because you're a diabetic. So it's, you know, all those things will come at you in a suggestive way, but unless you change your behavior, you know, eventually you're just going to rip that thing off your wrist or shirt or however those sensors are you know, monitoring your body, and, you know, move on with your life. So, again, I think it has to, that behavioral component of this in the next 5 to 10 years need to be embedded in the whole AI machine learning aspects of human interaction.
Heather, what's Geneia going to be doing in 10 years?
Sure. I guess before I answer, I would say I agree with Chuck 1,000%. I mean, that's sort of the next great frontier is we have lots of information. We just don't act on it. Oftentimes, we know what's good for us for the most part. We still fail to do it. So, you know, we'll just have more signs of, you know, that are telling us that we're not doing what we should, and we need to figure out how to crack that. Certainly, you know, I guess, you know, we'll be doing a whole range of things, but what excites me the most, I think, is the application of genomic mapping, and as well as Dr. Rob mentioned this earlier on, is taking in then other public health data sources, you know, air quality indicators, socioeconomic data, you know, other public health measures. You know, I think with genomic mapping, we're going to much more easily understand food tolerance, allergies, causes of inflammation that then ultimately lead to chronic disease. We might understand the biomarkers for disease onset, and we'll actually be able to then take personalized approaches to mitigation. And, you know, by way of example, there are 3.2 billion letter pairs that comprise the human genome. And in 2001, it took a full year and $100 million to map it. And now it costs about $1,000 and readily accessible. And we also have the computational power now that we didn't before, and analytic methods to deal with those. And now we can relate those, you know, those genomic markers with outside attributes, or these outside sources, these data points, whether it's pesticide application to vegetables, access to vegetables at all. We can be more precise in our prescribing so that we're giving the right dose to the right person at the right level, and we know that it's going to take effect, as compared to now where we try many things and they sometimes work for individuals and sometimes they don't, and we don't necessarily understand the causes why. And so, you know, it will take some time, even though it's more and more is happening now, it will take some time to get there to be able to put all of this to good use and get it socialized out into the marketplace, so that we can make effective use of it. But it certainly is an exciting time, you know, I think in our history in terms of having access to information and the means by which to interpret that information and hopefully then making behavior change or maybe just continuing to ignore it.
That's right. That's what I plan on doing. We have actually a couple minutes, just about 5 minutes for audience Q&A. We do have one question in. Let's go with you, Dr. Rav, on this. Among caregivers, who accepts AI most, and what kind of improvements do they want?
Well, among the presently is the researcher, and secondly are the physicians who are participating in that program. They accept the most artificial intelligence that we are working with. And the changes that they are asking for are the following. One is workflow changes for their own workflow so that it becomes faster at the point of care. And the second is that the people who are also asking for those questions are the people who are in population health, the physicians who get that information so that they can better help their patients in advance. Also, the questions that are being asked for us are chief strategy officers who help plan future, growth in healthcare and how to replan the entire population health plan, the entire the delivery of care plan. They are the people who are asking these questions because it depends on what you ask, let the machine ask. So there are questions that come for point of care, there are questions comes for behavioral change, and then there are questions people are trying to understand whether we are providing effective healthcare or not, or whether we are decreasing cost or not, and how we can make the biggest thing that we're working the AI on is to put preventative measures for people who are not yet sick so that they don't climb to that chronic disease phase. That's where we are now.
Excellent. All right, one more audience questions. Let's go with you, Chuck. With machine learning and AI, there is still the need to ask the question that the machine is going to answer. How do you select the question, and who has input into that process?
Well, I think you really have to bring the clinicians in, early in the conceptual stage of what you're trying to do with machine learning and AI. To me, that is the key. Getting them, we've got to learn the lessons of what happened with the electronic health record implementations in the past, and we're still going through some of that pain. And so, bringing the clinicians in, whether they're researchers, as Shafiq mentions early, they're educated, they want to, work with this technology. I think they're the ones. It's not the IT shop or the analytics people within IT that's going to create this. It's going to be the data scientists that are working, in the research side that will carry the ball on this. I mean, the power of this is going to be amazing. If you look at I see the pharmaceutical industry as being, very excited about this going forward, as it takes about 15 years for a drug to get to market. It costs about $1.5 billion. And the biggest part of that are the clinical trials that they have to go through, and it's because the cohorts that they're selecting are very generic and broad-based. And so if you can get using machine learning and AI and get to the point where you're selecting the right cohorts for the clinical trials, you can start to reduce the number of trials. And so you can imagine if you can go from 15 years to 11 years, save $750 million for a particular drug and get it to market to help people, how that's going to change the whole healthcare industry, over time. And just to me, it's just extremely exciting. But again, it goes back to getting everybody involved at the conceptual stage of starting this process in your organization.
Excellent. Well, that's about all we had time for today. When you close out your WebEx window, you will see a post-event survey pop up. It'll take you probably 30 seconds to answer it, so we would appreciate it if you do that. I want to thank our panel, Chuck Podesta, Dr. Shafiq Rav, and Heather Lavoie. I want to thank our sponsor, Geneia, for making this event possible. We truly appreciate the conversation that they've allowed to happen today. As I mentioned, we're recording today's event. Our archive will be ready within 2 business days, if not sooner. You'll get an email when it's ready. If you hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU. Be sure to let Chime know you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox, and if you need a certificate of attendance, you can use the final slide in this deck. Then you can go to our website to view our upcoming schedule. So with that, I want to again thank our attendees, our panelists, Geneia, and everybody have a wonderful day. Thank you.
Thank you very much.